Hi, I'm Dr. Castanet again. I told you I'd discuss with you referred pain patterns so that you're not misled about the source of your pain when you have back or neck pain that gives rise to pain somewhere else. Uh, Referred pain in the neck, we'll discuss that first. These charts here represent something we used to call sclerotomal pain. It's where different hard tissues refer pain in the body depending on their source. These have been designated according to the level of the nerve root. So for example, I don't know if you can see it well, but a problem, a lesion or problem. Lesion just means anything that's wrong anywhere. Could be physical, could be functional. So for example, a headache is a lesion, a wart is a lesion, a severed head is a lesion, you name it. Everything is a lesion. But we don't use that word often because it's not specific, and so it's not very helpful in most contexts. But anyway, it is in this case. So a lesion or a problem, for example, at C7, which is the seventh cervical vertebrae or vertebra. And again, there's 7 little bones in the neck. There are 12 in the middle back from the neck until about this part of the spine. Then there are typically 5 in the low back, sometimes 6. Then you have the sacrum at the bottom. In any case, remember these from C1, the first cervical, to the 7th cervical. Then we call these vertebrae between the neck and here, we call these thoracic vertebrae. There are 12 of those, again numbered from above down to 12. And then we number the low back vertebrae, L1 through L5. And you've probably, if you've had neck or back pain, you've had any imaging, you've probably heard referenced by doctors or in your report if you read it to these vertebrae by number. In any case, a problem at the C7 level in the neck is not felt just in the neck area. In fact, sometimes it's not felt in the neck area. It's felt somewhere throughout here, all this tan colored area. So anywhere in the scapular area here, the trapezius area here, it can be felt down the arm if there's a pinched nerve. The blue area here is for C7, so the area between C7 and T1. That can give rise to any of this blue area. If you look at this down here, this is C6. You see, by the way, these overlap a good deal. There's not a region that's particularly distinct to one area. There's some overlapping, so it can be a little bit confusing, but for the most part, it's important enough just to recognize that the pain is either like lower cervical area, middle cervical area, upper cervical area, and so that you know that that's the source of the pain if you're trying to interpret this referred pain phenomenon. It's, I'm going to stick with the upper neck and shoulder area. C3 is in the upper neck and shoulder area. If you look over here, this red area here is C6, again, more or less, and these vary a little bit from person to person. But the point is that if you look at all this in aggregate, any pain from about the bottom of the shoulder blade up that you feel is most likely referred pain from a neck problem somewhere in the neck. There are, different things you can do, like moving your neck in a way that provokes the pain. That helps us diagnose that the neck is the source of the pain. You just can't take on faith that pain in the thoracic area is coming from the thoracic area. In fact, the reason it seldom is, and I would say that pain in this area, anywhere from, again, the shoulder blades up to the neck area, any pain in this region, 95+% of the time is going to be coming from a neck lesion or problem. The reason is because the thoracic area, again, from here to about here in your spine, it's quite rigid. The discs are not the same anatomically. They're not as likely to bulge or rupture or herniate. They're not, the whole region of the spine is protected by the ribs. So it's not, and the demands on this area are not as great in terms of mobility. With our interactions with the physical world, we need mobility, and we impose demands on discs and joints that vary depending on the demands of mobility that we impose on it. So the low back, which is highly mobile, has a lot of demands, physical demands, including loading, as well as being mobile. The neck has a lot of mobility demands. And then the thoracic area, or right in this area, has relatively few demands. So it's much more protected, it's much less demanded of. It stays in an idealized position more often because it's more rigid. Whereas we get into awkward positions and do things that are pretty demanding in non-idealized positions in both the neck and the back, which again is another reason why they're more likely a source of pain. So you have to be familiar with these referred pain patterns, and usually an examination can determine the source of the pain with a great degree of probability. Not always. Sometimes it's a little tricky, and sometimes you need to test your hypothesis by doing a treatment that is presumably effective for a problem, say in the neck, and if treating the neck solely improves the pain where you feel it, then you can infer retrospectively that the source was in fact the neck because you treated the neck and this pain here got better. That's almost always what I do. But it's only been the last 16 years that I've been doing spinal decompression, which I've discussed before as the most effective means of non-surgical treatment I've ever used or encountered, that I could make this distinction and test these assumptions and see the results. And if you don't have access to this treatment and you don't see this clinically again and again and again, this whole referred pain concept can't be fully appreciated. But I've seen it happen so many times that I'm quite confident now when I explain to patients that with almost certainty, pain they have here, and this includes my findings on history and examination, is most likely coming from the neck. And then of course, if you treat the neck and it gets better and the patient feels better, then they've learned something valuable too. They've learned not to take this pain here at this place at face value and assume that they would benefit from having somebody treat them in this area. And I see providers treat this area for pain that's arising from the neck for weeks, months, years, and it's been a waste of time. Just because the pain is here doesn't mean this is the source of the pain. And again, it's usually coming from the neck. In terms of the low back, I'll move to that now. If you look at some of these pain patterns, this is where you might feel pain arising from an S1 lesion or the L5-S1 area, the lower back and the upper sacrum area. By the way, these pain patterns they differ for a variety of reasons. These are not the patterns you necessarily feel with a pinched nerve. You can feel these pain patterns if a nerve's not pinched, if it's just the origin of the pain is coming from a joint or a disc. So in terms of the low back, this area here, L5, if you had a joint-related problem in the low back, degeneration, arthritis of the pain of the joint, and it was arthritic, you can get pain in this region here. You notice it's the buttock area and the lower back area. It can go into the thigh, about halfway down the thigh. And again, these are generalities. This is the S1 area, all this purple area. L3, the lower back, can feel it here. Again, upper buttock and lower back area, and it can go down into even the leg area. Although typically we say that any pain beyond the knee is almost always sciatica, meaning it impugns a pinched nerve as the source of the pain. So you don't usually get what we used to term sclerotomal, what we now term myofascial pain. You don't get that kind of referred pain pattern typically in this area here, and we wouldn't diagnose this typically as a myofascial pain. If it was here, we'd likely call it sciatica. If you look at the front of the thigh, because this was the back here, if you look at the front of the body, the L2 area can be felt in the thigh here, in the blue area. S1 can be felt in front. These are a little misleading because they're not entirely accurate in terms of the probability or the extent to which they are seen in a clinical setting. Some of these patterns, more distally, are infrequently seen without a pinched nerve. If I look over here, again, getting back to the low back, etc., L5 could be in the front of the thigh here, L4 in the front of the thigh as well. You can also find L4 in this pattern. But the point is that if you have pain from your waist down, it's very likely coming from some problem in your low back. And there are also some less common pathologic entities like piriformis syndrome and sacroiliac problems. Those are very much uncommon relative to disc problems, joint problems, pinched nerves, those sorts of things. So that should seldom be the first guess at a diagnosis. But these things become mimetic in some sense in terms of diagnosing. There's a lot more, I think, for example, piriformis diagnosis than is appropriate. The sciatic nerve is a real common source of back pain. Sciatic nerve exists in the buttock and goes down the thigh, etc. So if you have focal pain in your buttock area, it's very seldom, in my opinion, a piriformis problem. A much more likely referred pain, which can include soreness to palpation of this area. And again, the way you would know is you start with whatever your hypothesis is, you treat it accordingly. If it responds, it confirms or affirms you're on the right track. If it doesn't respond, you need to reconsider and maybe consider some other diagnoses. I seldom diagnose piriformis problem. I frankly don't know how to diagnose this with any certainty. And but on the other hand, I also have a great tool for treating low back pain. So I decompress the low back, and then I see what responds to it. And almost everything below the waist that's painful responds to treatment of the low back because that's the most common source of pain. There are other entities that you have to differentially diagnose, like hip joint problems or bursitis and things like that. But those, again, they're uncommon entities. If you start with the assumption it's the low back and you treat that effectively and you see it respond, it helps diagnostically. And if it doesn't, then it means you need to question your diagnosis. In any case, that's the story on referred pain. If I can help you, I'm Dr. Castanet in Decatur, Georgia. My number is 404-558-4015. The website is backstrong.net, and I have a YouTube channel where you can watch videos that are instructional if you want more information, and that is, look up Dr. Castanet, Castanet. Thanks so much. Bye-bye.